So let us summarize the quantitative platelet disorders. First, we have discussed with the classification of platelet disorders. We have the quantitative and the qualitative, and we have studied the quantitative. So quantitative disorders of platelets may be due to decreased count, that is thrombocytopenia, or increased count, thrombocytosis. Thrombocytopenia is platelet count below the lower limit of 1,50,000 per cubic mm. And then causes of thrombocytopenia could be because of increased platelet destruction or decreased platelet production or sequestration or dilution. So these are the causes of thrombocytopenia. Now, clinical features of thrombocytopenia includes an excessive or abnormal bleeding. The size of bleeding could be cutaneous bleeding, mucosal bleeding, and then central nervous system intravenous bleeding. Severity of bleeding depends upon the platelet count. So if the platelet count is from 20,000 to 50,000, it is post-thrombotic bleeding. Lesser than 20,000 is spontaneous bleeding, and then lesser than 10,000 could be intravenous bleeding. Now coming to thrombocytosis, it is a condition in which there is an excessive number of platelets in the blood. So we have two types. We have the essential and we have the reactive or secondary. Essential or primary, or essential reactive or secondary. Coming to essential thrombocytosis, it is a rare disorder in which the body produces too many platelets for unknown reasons. And then the causes is because of the mutation. Important factor in the mutation called JAK2 mutation. And then diagnosis includes complete blood count, blood smear, genetic testing, and then bone marrow tests. So according to the WHO, the criteria for essential thrombocytosis are platelet count that is greater than 4,50,000, bone marrow biopsy, and then showing megakaryocyte lineage with increased numbers of enlarged mature megakaryocyte with no significant increase in the neutrophil granulopoiesis or erythropoiesis, and rarely minor reticulin fibers. That is very important to keep in mind. And then not meeting WHO criteria for CML, polycythemia vera, primary myelofibrosis, MTS or other myeloid neoplasms, and the presence of JAK2 mutation. Now coming to reactive thrombocytosis, we have it is a benign form of thrombocytosis. So in contrast with the essential thrombocytosis, it is an unregulated abnormality of platelet production due to a clonal expansion of bone marrow progenitor cells. So we have the pathophysiology here. Elevated platelet counts can be due to megakaryocyte proliferation, decreased platelet sequestration, or increased cytokine production, which stimulates the platelet production. So pro-inflammatory cytokines like interleukin 1, interleukin 6, interleukin 11 that occurs in the chronic inflammation. So elevated levels of interleukin 1 and interleukin 6 as well as C-reactive protein leads to the megakaryocyte growth and then increased production of platelets as a part of the secondary thrombocytosis. That is the pathophysiology. The picture showing increased megakaryocytes, hence we have increased platelets. So for the approach to reactive thrombocytosis, we have ESR, cytogenetic analysis, LAP, lab score, and then vitamin B12 assessment, and then ANA, RF, iron studies, peripheral blood smear, and then bone marrow aspiration and biopsy. So that is all about the quantitative disorders of the platelets. I hope you have understood. Thank you.